Dr. Beth Abramson, MD, is Associate Professor of Medicine at the University of Toronto. She is the Paul Albrechtsen Professor in Cardiac Prevention and Women's Health and the Director of the Cardiac Prevention and Rehabilitation Center and Women's Cardiovascular Health in the Division of Cardiology at St. Michael's Hospital. Dr. Janice Weiss is a family physician with over 35 years of clinical experience. Dr. Weiss is an assistant professor at the University of Toronto in the Department of Family and Community Medicine, and in 2015 became certified as a menopause practitioner with the North American Menopause Society. She is also a consultant to the National Ballet of Canada. All right. How are the two of you doing?
We're doing great because the world's turning right side up a bit and people are looking at aspects of their health that are important beyond the stress of the pandemic we're all living through.
Pretty excited about this one because it's such a necessary and topic. So I am going to share this screen. Okay, I'm going to leave it to the two of you.
Okay, can we get the next slide? So, hi everybody and welcome. This is a topic that is getting more and more attention. Women are speaking up and asking more questions, and we have a lot more answers than we had maybe 10 or 15 years ago. So it's really exciting and lots of new things happening in menopause. So we're going to just start by talking about what is menopause, what are the definitions, so we set the stage for what we're talking about. Chris, next slide. So technically, menopause is a normal natural event. It's confirmed retrospectively 1 year following your last period. So you get your period, you wait a full year, and then you've hit menopause. If you get a period 11 months later, then we wait 11 more months, or 12 more months, I should say, and then you are in menopause. Perimenopause, we hear people talking about, that's a period in the time in a woman's cycle when the cycle starts to become irregular all the way through till the period ends. That's the transition called perimenopause. So menopause is considered normal anywhere from the ages of 40 to 58. Huge range, but it's all considered normal. The most common age is 51 or 52. If the final menstrual period occurs prior to age 40, it's considered premature. If it occurs between ages 40 and 45, it's considered early, but it's still in the normal range. The reason we mention that is because there are some pretty significant health implications of going through early menopause, and we'll speak to that near the end of the seminar.
Yeah, and we want to talk about midlife and what's normal and what questions people need to ask. And you know, there may be some men on this call as well, because it's actually important that you understand what's happening to family members, to co-workers, and we deal with issues that may be normal, but may have health consequences or symptoms associated with it, and we need to ask the right questions and talk about the issues.
Absolutely. Okay, menopause used to be considered a topic that no one talked about. Women considered it something they just had to suffer through, go through. Older days, they were more male doctors than female doctors, and men unfortunately didn't always understand it. Times were different then, but we have a lot more educational experience for medical students, for residents, a lot more doctors who are very knowledgeable and we're there just basically to guide you through the transition. I always make the comparison to going through puberty, where you have your mom and maybe older sisters or friends that kind of sort of guide you through puberty, but there's not always the same family support to guide people through menopause. And sometimes people look in the wrong direction or in a direction that we don't necessarily advocate as being the best direction. So that's what we're here for, is to help to guide you, to help you to go to the sources that we consider credible and evidence-based medicine currently.
Yeah, and I think it's the concept that it is no longer a taboo topic, and we're here to help. Dr. Weiss has expertise. She's certified with the North American Menopause Society. So, you know, there are experts out there and there are people with understanding of what happens. And I think over the years, we've all wanted people to be proactive about their own health. It's okay to ask. It's not a taboo topic, and there are changes that occur in a woman's body at midlife. on average age 51, but can be happening earlier, sometimes a little too early, and we need to talk about that, sometimes later, and it's not taboo anymore. I totally agree with Dr. Weiss.
Especially the sensitive areas. There are some aspects that are even like much more common and comfortable to talk about. And then you'll see, we'll get into some areas that people consider a lot more sensitive and
Yeah,
personal and maybe a little more reluctant.
and I think as healthcare providers, people listening and seeing us need to know it's okay to talk about it. It's okay to ask. Healthcare providers need to ask their patients and clients and patients and women and their supports, male or female, need to ask their healthcare providers. It's not, someone will walk into my office and be comfortable talking about chest pain, but they won't talk about irritability and sweats because they're not sleeping at night. And it's okay to talk about it. And I think we're embracing that as we move forward. Yes, sorry, yeah, there we go. Keeps running off.
Okay, so just basically there's some fairly classic symptoms that people know about, and then there's some other ones that are probably less known about. So the very first symptom of menopause is cycle irregularity. There's really not much to do about that. But if things are really wonky and you're really not sure about it, go on and talk to your doctor, because there is still, even though that there's an irregularity, sometimes that can represent uterine cancer. And we are able to sort of pick up the nuances of what is normal menstrual irregularity in early perimenopause and what might represent something more pathologic. So that's really important to bring to someone's attention.
Yeah, and can I just add to what Dr. Weiss is saying? If you are a woman who's gone through menopause and midlife and your menstrual cycles have stopped, and you start bleeding well over a year afterwards sometimes. So let's say we're talking about women at midlife, perhaps in their 50s. If you're a woman who's listening, who's in her 60s and your menstrual cycle stopped a while ago, that's never normal. And you should always talk to your doctor about it. So post-menopausal bleeding, periods have stopped, you've gone through midlife, dealing with symptoms or not, and then you start to bleed again is never normal. Seek medical attention. Right, Dr. Weiss?
100%.
Just a cardiologist, what can I say?
You are the best cardiologist, so diversified, I love it. The other classic symptoms, as most people would know, would be what we call vasomotor symptoms. So that would constitute the hot flashes and the night sweats. And that's something that we all kind of laugh about and fan ourselves and, dress in layers and basically cope with. Those are self-limiting for the most part. The majority of women will outgrow those. They're worst in the first 2 years. They can last technically 7.4 years is the average, but it can about that time. But about 15% of women do not let go of them. They just stay with them for life. So there are some women that just go on, and there are things that we can do about it. The symptoms that are not talked about commonly are what we refer to as the genitourinary symptoms of menopause. And we will get into more details about what that constitutes. And I'm happy to field any questions about what to do about those if they come. The other symptoms that are common are sleep disturbances, cognitive concerns like memory and concentration. And some people say they go through menopause and don't remember any aspect of it. It was one big blurry time. Psychological symptoms, mood symptoms, joint aches and pains.
Yeah, and I think it's actually it's actually tricky to sort it out. So it's a conversation that has to be had with a patient and a provider. So is somebody having true memory issues, cognitive decline? There is data on there that there is cognitive decline when estrogen levels fall for a woman. Or are you just not having memory issues? Is a person not having memory issues because they're not sleeping at night? Because if any of us are sleep deprived, we will not be functioning well. And so teasing out what is true depression and anxiety, memory and concentration related to aspects in the brain that are imbalanced versus you're not sleeping and we need to get you to sleep so you can function to where you need to know, are sometimes complicated and hard to sort out, and are very important for obviously our female patients.
It's the chicken and the egg. All right, let's go on. Okay, so we'll talk a little bit about these vasomotor symptoms, the hot flashes, night sweats. So some people can identify the triggers, commonly hot beverages. So it could be a coffee, a tea, soup, anything that's hot, especially if you have it in the evening. Night sweats are almost always worse. Spicy foods can trigger it in some women. Alcohol for sure can trigger it, especially if you have a drink in the evening. Night sweats are generally worse. And stress can trigger it. There are different approaches that we take to treating it, and I'm happy to field specific questions, but for now, we look at hormone treatment, which was an issue back in 2002 when there was this huge study called the Women's Health Initiative was published. Actually, it was stopped early because of concerns about safety with respect to hormones. And we understand the nuances of what went wrong with that big trial now. And used in the right women at the right time in their lives, hormones are very safe. So we can get into more detail about that afterwards. There are also non-hormone treatment options that are prescription. There are over-the-counter supplements that most women have tried, and I'm telling you, they do not work. All randomized controlled trials of these supplements have never shown them to be effective. Symptoms wax and wane. So sometimes people will say, I took a supplement and it worked. Most likely those symptoms were going to get better anyways.
But they work on draining our pocketbooks because there are people spending a lot of money out there. And, you know, it is interesting that people spend almost more money and are willing to spend more money on more alternative and non-prescription medications than the prescription drug market. And it's not that we're prescribing pills, but to spend on something that is not effective and that might even be harmful in terms of long-term, depending on what we're talking about, when it's not evidence-based, is a concern. We want to make sure women are getting the right care based on the evidence.
Yeah, and they just don't help. And then the only other thing to be wary about, and this is a huge topic, and probably it could take a whole webinar, but the concept of compounded bioidentical hormones. So in a nutshell, bioidentical hormones are hormones that are chemically and molecularly the same or pretty close to what the body produces. They can be either Health Canada approved prescription bioidentical hormones or compounded bioidentical hormones. So compounded bioidentical hormones are in some ways an alternative approach to the prescription medication. They were initially intended for women who had allergies to the prescription medication or required specific dosing or formulations that just weren't appropriate in a commercial sense. The concern is it is an unregulated industry. There is no consistency. We don't know for sure about absorption, and there can be concerns. So a lot of women think of them as safer. They are not necessarily safer. The other reason that they appear safer is that there's no insert that is put into a box that you get commercially because it's not mandated by law to do that. So the risks are not necessarily in your face. So it's just and I know a lot of people use them, but it's not something that is advocated by mainstream medical care.
Yeah, and I think it's something we have to just reinforce. Just because something seems natural or alternative doesn't always mean it's safe. I mean, I am a heart doctor at the end of the day, and digoxin or digitalis, which we use as a powerful heart medication, comes from a natural herb foxglove. So, you know, things that are controlled and we know what's going into our body and we can make those decisions on and make educated decisions on are much safer for all of us than things that may not at first say they're natural, but may actually be harmful and not as helpful as we need as well.
Yeah, the prescription basically has rigorous testing and quality control, and we know what the risks are, and we know what the issues are. So next slide. Okay, so this is the topic that becomes a lot more sensitive, genital urinary symptoms. So that could include things such as stress incontinence. And stress incontinence is that phenomenon where you jump or you sneeze or you cough and you go, oops, you leak. Urge incontinence is a different type of urinary incontinence where you can't make it to the bathroom on time. You just kind of go, uh-oh, and you leak. Genital urinary symptoms can also include pain with intercourse, irritation, dryness, or discomfort, just general kind of not feeling great about it, about how you feel. A lot of women, I'd say the majority of women, consider this a normal part of aging. Unlike hot flashes, which most of the time resolve on their own over time, genitourinary symptoms do not. They don't abate, they continue, and they typically become more progressive and worse as time goes on. I usually recommend to patients that if you start having any difficulty with dryness, irritation, pain with intercourse, etc., get treatment early. The earlier you treat yourself, the better your long-term result is. There are also ways of treating both stress incontinence and urge incontinence, and you do not have to live with that. Next.
So it's also something that people don't talk about, right? They don't always come to their doctor. And I know as a people will never mention that to me. I am a specialist in another way, but I take care of the whole individual, so the whole woman. And I don't think in my 20 years of practice anyone has had that concern to me. And I'm sure as a family doctor and an expert in the area, you see people coming, but less frequently than they should. Is that?
I have to, you're right, absolutely. I have to ask patients probably 95% of the time about whether or not they have those symptoms. Yeah, and
it shouldn't be taboo, right?
And I think that, yeah, patients don't ask me, I have to ask them, but I would also have to counter that and say a lot of physicians don't ask their patients either.
Yeah.
Because not everybody feels comfortable on how to address the management. So if you have an issue and you're not comfortable, just ask your physician if they are knowledgeable to help you or to send you to somebody who is able to help you with that.
Right.
Okay. Sleep and mood. Okay, so sleep disruption can be caused from several factors. So there's the psychological factor, and this is huge. This is a time in midlife, you're going through a transition, you're possibly have work-life balance issues. A lot of people are working full-time. Either they have kids at home still that require their attention, or they're dealing with the stress of being an empty nester, or having aging parents and being in that sandwich generation. So midlife stress can bring out a sleep disruption. There's anxiety and depression that are really quite common in the menopause transition. Some women are very sensitive to the hormone fluxes, and that can bring out anxiety and depression. And especially if you've experienced it earlier in life, then that can come out more. And especially if you've had, this is actually an interesting thing, women who've experienced an adverse childhood event, whether it be some kind of traumatic emotional event in their lifetime, whether it be war or physical trauma, rape, serious family discord, anything, moving from a war-torn country, anything like pretty traumatic as a child, it can come out in menopause, in the perimenopause time, as worsening of hot flashes than otherwise might have happened, and even mood disorders. Those issues can come out more. So it's a common time for women to be sensitive to the fluxes in their hormones. So that's the psychological factors. Those are the hormone factors we just mentioned that can also cause night sweats and sleep disturbances. And then you have physical factors that come with general aging and menopause. So sleep apnea is more prevalent after menopause when you lose your hormones. Joint pains are really common after in the perimenopause transition and afterwards. Arthritic pains, bladder irritability, getting up at night, all these things can interfere with quality of sleep. So we look at quantity of sleep and quality of sleep. If the quantity of sleep we look at, we aim for about 7 hours of sleep at night, 6 to 8 would be reasonable. But if you're not getting the quality of sleep because it's being disrupted by either one of these psychological factors, hormone factors, or physical factors, that can be quite distressing.
Yeah.
Okay, this is where we need our cardiologist, Dr. Abramson. Before we get to her level of expertise, we're just going to talk about one other issue first. So there are some serious health concerns, conditions that can develop after menopause, especially common in women who experience early menopause and premature menopause. And those include things like osteoporosis, cardiovascular disease, and cognitive decline. We're going to focus on the cardiology aspect because we have some expertise here, but I'll briefly touch on the next slide, which is the osteoporosis, which in the first 3 to 5 years after menopause, women lose a significant amount of their bone. It predisposes them to fractures earlier in life than men do. One of the earliest fractures that women might experience is a fractured wrist from falling. Falling from standing height or within 3 steps height. It doesn't matter how slippery or hard the surface is or how hard you went down, bones should not break. So if you've broken a wrist under any of those circumstances after age 40, it's considered an osteoporotic fracture or a fragility fracture. That has to be taken very seriously. What we can do is, in order to help prevent a more significant decline in bone quality, is to ensure that you're getting enough calcium and vitamin D. Calcium is ideally 1,200 milligrams a day, which would be a combination of dietary and supplements, preferably from the dietary sources is what is recommended. Vitamin D, on average, we would take about 2,000 international units a day, taken with food to help absorb it better. And if you're a Medcan client and you've had your AHA, then you will have your vitamin D levels checked. And we look at maintaining a vitamin D level at least 75 or higher. It does not, higher than 75 doesn't impart any extra benefit. As long as you're at the 75, then that's fine. Weight-bearing exercise, balance control and improvement are also really important to help prevent falls and to build bone strength.
I'd also add, because we're going to go into other risks for heart disease, dietary calcium is important, but we need to make sure we're eating low-fat dairy products because for people who I see with high cholesterol, and these can be postmenopausal women or people at all levels of life, it's my foodies in my practice who like cheese and cheese boards. It's actually calcium is important, and I use skim milk in my coffee in the morning and have fat-free yogurt, but going to the lower fat dairy products as a routine is a good way to lead yourself in the right direction for both heart healthy behavior and wellness for bone health as well. And I think that's regardless of your biological sex or gender.
Excellent point. Absolutely. Okay, Dr. Abramson, take it away on cardiovascular.
Well, you know, cardiovascular disease, heart attack and stroke is really a leading cause of death and disability for all of us. But for women, I mean, heart disease is no longer a disease of old gray-haired men. And if we look at this, it's the leading cause of death for women over age 65. It's the second leading cause of death in women at midlife, 45 to 64. And there's increasing evidence, actually, that young women, there are a certain population where we're seeing heart attack rates increasing in the population in the last decade or so for the first time. And some of this is related to being overweight. Some of this is to diabetes and high blood pressure. And I just add in, if you are a person or know of a friend or family member who had high blood pressure or diabetes during pregnancy or preeclampsia, that woman is at risk for cardiovascular disease at an earlier and accelerated pace. So, you know, we need to take care of our risk factors for heart disease. And heart disease risk factors include high blood pressure, diabetes, high cholesterol, smoking, or a family history of early heart disease. And a woman's risk for heart disease starts to increase after midlife and really take off. Women in general, this is a generalization, I have lots of younger and midlife women in my practice, but women develop coronary heart disease 7 to 10 years later than men. It's an equal opportunist, I say. And so if you, for a family history, if you have a father who had a heart attack in their 50s, whether you're a man or a woman, your risk is higher, but that woman will more likely to develop symptoms, risk factors and symptoms 7 to 10 years later than men. And a woman's risk really starts to take off after menopause or midlife when estrogen levels fall in the body and estrogen to testosterone ratios change. You know, we've talked about symptoms and there's a lot we don't know, but many of the things we are seeing in terms of risks for women as they age and symptoms of menopause are related to hormonal changes. And so there's no doubt that when estrogen levels change in your body, risk factors for heart disease increase. High blood pressure, tendency, diabetes, high cholesterol, and the shape in which we are changes as well. So younger women tend to gain weight and fat in a gynoid or apple-shaped distribution. And the good news, good and bad news, is if you have extra weight across your hips, that does not put you at risk for heart disease or heart attack and stroke. But the android or male distribution, apple-shaped, right? I kind of say, we'll call it a beer belly if you want, shape, actually puts you at risk for cardiovascular disease. And as women age and go through midlife and menopause, they tend to gain weight, and they go from the pear shape that they may have gained when they were younger to the apple shape. Your actual fat distribution changes. Now, I will caution you, you can't be a big pear because you have an increased weight across your waist and then extra weight across the belly, across your hips as well. But it's the weight across the belly that is the dangerous fat. And dangerous fat puts us at risk for this diabetes, for the high blood pressure, for the cholesterol. And so I think we do need to take midlife as an opportunity, and we being women and healthcare providers, to talk to their doctors, not just about symptoms, because you may not have symptoms or changes in your body, but what are my risk factors for heart disease? Because it's our leading health threat. And I think as we age and mature, it's never too late, never too early to make a lifestyle change. So you don't have to put on spandex and be a skinny mini or run to the gym every day when the gyms are open to be healthy from a heart perspective, but incorporating activity into your routine, making sure risk factors are controlled, aiming for a healthy body weight as we're going through these changes and having stresses are truly important. So those are some of the things I wanted to talk about in terms of midlife or menopause. And I think we have more to talk about in terms of treatments as well.
Yeah, no, I think those are all fabulous points. And I always suggest to people, as soon as, like, I use every opportunity of seeing people to emphasize the importance of being proactive about their health. So start exercising early before it becomes a problem. It helps your bones, it helps your heart, it helps your brain. There's nothing, no downside to exercise, and any short-term injuries has greater long-term gains. So eating healthy, exercising, making sure you get adequate sleep, super important, and you can't start that too soon. The earlier in life you start it and you maintain it, the better off you are after menopause.
Yeah, and if you are someone listening who has not been that active but is going through midlife, it's still okay to start. And walking, I mean, we've all walked a little more, hopefully, in the last year or so than many of us had before, out of necessity. But that was the silver lining: getting out there, being active, walking, truly important, and taking that midlife opportunity to think about one's heart health and future risk factors for heart disease.
Exactly. We have a few minutes. We can maybe just touch quickly on some treatment options. There's obviously the hormone therapy that we talk about. That's the gold standard for treating hot flashes. So estrogen is the most common hormone. The downside with estrogen, there are several downsides. Beth can speak to, or sorry, Dr. Abramson, I'm sorry, can speak to some of those in a moment. But basically the imminent concern is that it can build up the lining of the uterus. And by building up the lining of the uterus, it can theoretically cause cancer of the uterus. So we have to counter that with one of several options to prevent that from happening. The most commonly used one is progesterone. So you would use estrogen and progesterone. Estrogen gives you the symptom relief, but progesterone prevents that buildup of lining and prevents uterine cancer. Sometimes women if they have an IUD in, like a Mirena IUD that has some progesterone in it, if it's already in place, a lot of doctors will say, well, that's already doing the same job. It's an off-label use of that IUD, but it definitely does the job as long as you're being monitored. And then there's a third option. There's a type of medications called SERMs, and it comes combined with an estrogen pill, and that counteracts the buildup of lining of the uterus. There are some other great benefits to having that medication because it doesn't affect the breasts in the same way as as progesterone might, for example. So for people who have fibrocystic breast, tender breast, family history breast cancer, concerns about breast cancer, that might be something to discuss with your doctor as an option. For women who can't or don't want to take hormones, there are several different antidepressants that are often used, and they don't work as well as hormones do, but they can work not too badly. They're especially important if there's a mood disorder, that's causing sleeplessness. So then it's a win-win for sleep, for mood, and taking the edge off of the hot flashes. There's another medication that's called gabapentin that doesn't really help with daytime hot flashes. It helps more significantly with night sweats. You start low, you gradually build up, and you stick with the lowest effective dose that works for you. And finally, there's a medication called clonidine, which has traditionally been a blood pressure medication. It takes the edge off. If all else fails and you just need a little bit of help, then that might be the one. It's not as commonly used, but it can certainly help. Next slide.
We've got some, actually also, we've got a few questions also. So I want us to go through what we're talking about, and I want to make sure we'll have a little bit of time for the Q&A as well, because I've got some great questions to discuss after, but I want us to go on. But someone has asked a question. If it's okay, I can just bring it up because it's about what is menopause. And if that's okay, Dr. Weiss. So a woman has asked that she's had a hysterectomy, but her ovaries were left in. How does that affect menopause? And I think that's a great question. The reason a woman's ovaries are left in is to protect them until midlife so that they have functioning ovaries so that they can secrete the estrogen and the hormones that a woman needs until midlife. And so that is why a hysterectomy alone or a hysterectomy with partial taking out of an ovary is often done in younger women. It's often performed in younger women to protect them so that women can go through midlife around age 51 or so, 51, 52. The thing is, though, if some women are not having symptoms, we don't know of menopause, we don't know when that happens. If you don't have a womb or your uterus is taken out for periods. So those women sometimes go through slightly earlier midlife and menopause and need to be checked with blood tests and check hormones, unless you're having symptoms, to make sure you're not going through an earlier midlife or menopause, because we're going to talk about this, that younger women will need to be replaced. I think that was a really good question. Do you have anything to add, Dr. Weiss?
No, I think if the hysterectomy is past age 45, then I'm not concerned about giving them estrogen back because their menopause can't be early or premature. And then either they'll have no symptoms and just go through menopause, in which case it's fine. Or if they do have symptoms, then that's the answer, then that is menopause. So I don't personally do blood tests to prove menopause. There's no need for it.
Okay.
Unless, as you said, it's below age 45 and we
Right.
might need to use estrogen to replace them to prevent these chronic health conditions, which we talked about.
So that's, yeah, so we're talking about truly the younger woman going through early, but yeah, good.
Exactly. And along those lines, a lot of women will come in and say, well, can we do a blood test to check my hormone levels to see where I am in this perimenopause transition? And the answer is no. There's no need, there is no reason or efficacy to doing a blood test because it doesn't show anything. And there's fluctuations and variations in your estrogen levels that don't predict when that menopause is going to be. And on the same token, testosterone levels are often asked because of potential changes in libido, and they want to see what their testosterone level is. And again, that has no bearing. Testosterone doesn't change significantly before and after menopause, and it has no bearing on a woman's libido. So I don't test for that as well. Women who have gone to alternative clinics and they do saliva testing, I don't advocate for that. I think that's there's no evidence-based science in that type of testing.
Yeah, speaking of evidence-based science, we've got some evidence. We've got some good questions about how long people can go on stay on hormones for. And this is a discussion that Dr. Weiss and I had the other day because we have some data out there for women. We have more data than we've had in the last 15 years about the risk versus benefit of hormone therapy. I'm going to start off by saying, and we're going to have this conversation, Dr. Weiss can go through a lot of these slides as well, is that hormone therapy is used for the symptoms and moderate to severe symptoms of the menopause. And so severe vasomotor symptoms, sweating, not sleeping, severe irritability. If you are a woman who is not having severe symptoms of menopause, it is not recommended to go on hormone therapy at any point. So because we weigh the benefit, which is reduction in symptoms, against the risk, which we're going to talk about, which has to do with concerns about cancer and cardiovascular disease and where that plays out. And in general, I know Dr. Weiss is going to go into details, the risk if you are taking these hormones for severe symptoms of the menopause for a few years, in general, for the right timing for you as you need it for your symptoms, the risk is minimal. And therefore, hormones are recommended now for quality of life. Okay. But we do not use hormones to prevent heart disease. We do not use hormones solely for osteoporosis treatment. There are good drugs out there for osteoporosis. We use hormones in women who are symptomatic. And then there are added benefits and risks of hormones. So with that, I'm going to have Dr. Weiss go through some of this because people are asking in the Q&A how long women should be on hormones for.
That's a loaded question. We can probably debate this back and forth for a long time. It used to be said that women should be on the lowest dose of hormones for the shortest period of time. That conversation has now changed, and it is really a shared decision-making process between you and your physician that balances benefits, risks, and quality of life. So the benefits of taking hormones, as Dr. Abramson said, would be a reduction in your hot flashes. It actually does help with osteoporosis, although that wouldn't be a first-line approach to using hormones. There are reduced rates of diabetes taking hormones. You get improved sleep, you get improved mood, you get improved joint aching, and you get an improved fat distribution where you don't have the same amount of visceral or abdominal fat. So there are a lot of pros. And especially if it's early or premature menopause, you're going to get the added benefit of cardiovascular disease, Alzheimer's disease, and osteoporosis, as well as reduced a lower death rate, believe it or not. So they're significant benefits.
Right. So I just want to comment on what Dr. Weiss has just said so people are clear. There's taking hormones at midlife because you're having symptoms, and then there's replacement until midlife if you've gone through an early menopause. And so if you are a young woman who had her ovaries were taken out or went through early menopause in their 30s or age 40, that is early or premature menopause, as Dr. Weiss has talked about, and those women should be replaced for all the benefits. That is completely different than the people women at midlife who are having symptoms or not. And the question is, should I be on hormones and for how long?
Right. Thank you for clarifying that. Exactly. Then there are risks involved. The risks include a very small increased risk of breast cancer. And if we go back to the slide, the previous slide, please, just for a minute, I wanted to put this in perspective. So the breast cancer risk increases in women who take estrogen and progesterone primarily. And if they're taking it more than 3 to 5 years, it goes up by an extra 1 case per 1,000 women. So there's a baseline level of the number of cases of breast cancer that would be expected in 1,000 women who aren't on any hormones. That number goes up by 1 extra person for every 1,000 women after 3 to 5 years of being on a combination of estrogen and progesterone. After 8 years of taking it, it goes up by an extra 3 cases beyond the baseline expected level. And after 12 years, it goes up by an extra 8 cases per 1,000 women. Go on.
Go ahead.
Yeah.
No, I was going to say, so what Dr. Weiss is showing is that the risk is low. The risk, although low, increases with duration of therapy, and that one has to reflect on how often one assesses symptoms and re-challenges or says, is this time to come off my hormone therapy or not? Because you don't want to add any even minimal risk, although low, if some symptoms are going away. And there's been a really neat long-term research study looking at these women in the Women's Health Initiative, and showed from a cardiovascular perspective, it's actually probably safe to take reasonably short-term hormone replacement therapy. But on average, the women were not taking hormones for 12 years. So we were talking about 4 to 5 years, 4.7 years on average of combination hormone therapy, and about 7 years of we call unopposed estrogen. So I do ask patients coming to see me with cardiovascular disease, and I know Dr. Weiss and I talked about this. She's an approach for patients in her practice, for women in her practice, to reevaluate the need for hormones every year or so, because it's not an indefinite treatment. And I've seen 80 and 90-year-old women who like the skin changes of estrogen, but I'm sitting there worried that they're going to get a blood clot in their legs. They should not be. We do not recommend women over 60 initiating or beyond 10 years out of menopause initiating hormone therapy. So it is an interesting conversation with interesting questions. I don't know if Dr. Weiss wants to add anything there.
No, basically, it's the important thing is as long as it's initiated in women under 60 and within 10 years of menopause, it's considered safe. After 5 years, it's a shared decision-making process. Speak to your doctor each year and say, should I continue? Is it worth trying to wean down or come off and see how I feel? And it's a quality of life, risk-benefit conversation. So the other risk that we need to talk about is the cardiovascular risk, the clotting risk that maybe you can speak to.
Yeah, well, estrogens are hormones. And the thing about a hormone is the definition of a hormone, it has more than one effect in the body. So if the only effect that the estrogen had would be to reduce the sweats and the irritability and allow us to function as women at midlife, that's great. But there are other hormonal changes. And we know, as we're sitting here talking about blood clots, very much on people's minds now when we're talking about clots related to vaccines and things, that women during pregnancy are at risk for blood clots in their legs and lungs. And the blood clot risk for women in pregnancy is related to estrogen doses. Now, those doses are much higher than the doses we give for hormone therapy afterwards. So I don't want to equate the two, but I want people to have a bigger picture understanding. And there is no doubt that there is an increased risk of clotting in our legs and potentially serious clotting in women at all stages taking hormone therapy and estrogen replacement therapy. However, we have to weigh that risk against benefit, as we've said, and the lower doses of estrogens. And although not on a label, but estrogens taken, for example, on the skin that don't go through the liver are likely to have, so there are postmenopausal estrogen replacement gels and creams, not just gel on your face, but you put a little on your leg or your arm or the belly, dosed out, a metered dose of estrogen. That is likely a safer alternative in terms of clotting. But there's no doubt if someone has had a history of blood clots during pregnancy or otherwise, we would be very cautious and be concerned and not recommend hormone therapy. Again, we weigh risk versus benefit, and it's an individual conversation with you and your healthcare provider based on symptoms and based on risk.
And just in terms of talking about dosing, to put things in perspective, the typical dosing of a birth control pill versus the typical dosing of hormone therapy, it's about a quarter of the birth control pill.
Yes.
So women, there's a lot of talk about scares and dangers, but they're on the birth control pill. Well, you're going a quarter of that dose.
So absolutely, these are generally safe and well tolerated. But as a woman ages, and this is that over 60 warning sign caveat, that our risk for clots and cardiovascular disease and issues related to the heart does increase. So I think in the younger, when I say the woman at midlife in her 50s who starts hormone therapy early for severe symptoms, the risk is outweighed by benefit, absolutely, with low doses. But as women stay on their hormones because they're feeling well, or they've switched and haven't seen their family doctor in a while, or something's going on, they're in a walk-in clinic that shouldn't be represcribing without thinking, I think we have to pause and have thought that as you are older, clotting risk does increase, even though it's safe at midlife for most women.
Exactly. Okay, let's carry on. Right. So as we mentioned before, menopause is an opportunity for lifestyle change. If it hasn't been implemented already, it's never too late to live a healthier, cleaner life. Eating healthy, exercising, sleeping, socializing, taking care of all the different elements of your health that could, bode you well in the long term. Next. basically this is the same thing. Not smoking, be careful with alcohol. One little point about alcohol. Our society has a fascination with alcohol, but one of the things that's not talked about a lot is the effect alcohol has on the incidence of breast cancer. So I challenge all you guys, just Google alcohol and breast cancer, and you'll be amazed at the connection that exists there. As Dr. Abramson mentioned, limit fat and cholesterol to optimize your cardiovascular future. Try to keep a healthy caloric balance to maintain a healthy weight. Eat healthy, make sure you get your calcium, low fat calcium and vitamin D, and exercise regularly. I think we've said the same things many times, but these are very, very important principles and not to be taken lightly. And here are some resources if you want to look up anything particular. The two places that I direct patients to commonly are one called Menopause and You. It's the Society of Obstetricians and Gynecologists of Canada, and the website is in front of you. North American Menopause Society also has fabulous podcasts and resources for you to look up individual issues. There's a podcast that you can listen to about menopause where women share their experiences. And there's a phenomenal book called The Menopause Manifesto by a very entertaining and well-educated gynecologist named Dr. Jen Gunter. And she's a Canadian-born gynecologist who now practices in California. And I know she has an upcoming webcast. I'm promoting it for Medcan. And she's super entertaining. And I highly encourage you to listen to what she has to say.
Yeah.
And we're open to any suggestions any questions and anything that we don't address during this webinar. If you want to submit them, either Dr. Abramson or I will answer and get back to you.
I also see there's some questions here. We can look at I don't know if Dr. Weiss can see on the Q&A. There's some questions. There was a first question here, and we'll scroll up, but I'm going to answer one as Dr. Weiss is looking. What are the symptoms of a blood clot? So a blood clot that occurs in the veins causes a buildup of blood flow in your legs. So a clot in your leg can go to your lungs. That's the way the veins go. The blood goes from your legs to your lungs and cut off the circulation, and it can actually be fatal. A clot to the lungs or pulmonary embolus, which is why we always want to be careful about diagnosing, and we can treat a blood clot if we catch it with blood thinners. So a blood clot symptom is a painful swollen leg. If you're at risk, and you're at risk for blood clots, if you're a pregnant woman, if you're on prolonged travel, which I don't think many of us are recently, and you've been sitting without moving your legs around. You know how they say on airplanes that you have to move and bicycle a bit, or you're on a prolonged bus ride or train ride. Prolonged travel doesn't allow the blood to flow as nicely, but getting up and moving around, prolonged sitting still puts you at risk for blood clots. And actually some people with certain medical conditions and cancers are at risk for blood clots. But so the symptoms are a swollen, painful leg. And I'm going to let Dr. Weiss answer the question she wanted to. And if you have that, it may or may not be a blood clot, but it should be checked out to see is it or is not. There's some easy testing and then treatments for that. Dr. Weiss, do you want to carry on with?
Okay, so I'll comment on the question about the bioidentical hormones. So somebody wrote, I have bioidentical estrogen prescribed by a naturopath that I apply topically twice a week. I've been thinking of it as safe, and for sure it has made a big difference to vaginal dryness. I'm under 60 and about 5 years into menopause. Do I need to worry about the estradiol? Absolutely not. So number one, I'm hoping it's a commercial product, something like Vagifem or Estragyne or even Premarin. Vagifem and Estragyne are both estradiol compounds. They're commercially made and they're safe and effective. And using the right dosing is perfectly safe. So I'm assuming it's one of those two brands and not a custom compounded medication. Using it twice a week is fine, and you can use it for life. When we're talking about the side effects of estrogen, we're talking about what we call systemic estrogens. That means getting it into your bloodstream either through your skin or taking a pill. This is topical estrogen, or what we call local estrogen therapy, that's applied to the vagina. And you can continue to take that indefinitely. As long as it's the prescribed dosing, you're safe. If you're going above the dosing that's generally recommended, then I wouldn't consider that safe. And then there may be a buildup of lining in the uterus. And that's my concern about not using commercial products.
Yeah, I think that's the concern, right? So if someone's having been prescribed by what one thinks is a dose of estrogen, which we recommend, and they're getting too much, they're actually at risk of malignance, of cancers, of malignant cells. So, and if you're not getting enough, you're not having symptom relief. So I couldn't concur more with Dr. Weiss in terms of making sure that you are working with the provider if you feel comfortable with, if it's that naturopath, getting prescription medications, not bioidentical.
Exactly, but absolutely, if it is a prescribed product, you can use this for life, and you know, you're fine. You should be fine. Okay, but again, if you have any symptoms of bleeding, it definitely needs to be addressed. And I think the last one I see here is, what are your thoughts on urine hormone metabolite testing to test whether estrogen dominant and estrogen not being cleared? I'm going to answer that I have never heard of it. I have no knowledge of it, and I don't think this is mainstream medicine. But because I don't know.
I think actually when we come across questions like this as well, when we're not aware, and it's not likely to be mainstream medicine, go to credible sources. So Dr. Weiss has actually, Dr. Weiss has suggested we look on websites. So the North American Menopause Society and the Canadian Society of Obstetricians and Gynecologists also has a website, and I've been involving their menopause guidelines for their heart. And so I think that not mainstream may not be appropriate, but there may be evidence that we don't know of. I would caution people to go off in our Twitter era of getting the real news on this. And the real news can be found at medical organizations that are national organizations, and that's where I would go.
Yeah. I don't claim to know everything about menopause. Obviously, I'm not a super expert, but I have been practicing this for many years. Go to a lot of conferences, I do a lot of reading, and I haven't come across that. So it's not commonplace.
Yeah, I was going to say Dr. Weiss is underestimating herself. She is an expert on menopause. I was not suggesting that this is something that is mainstream, but I'm just trying to tell people that when you're not sure it's not mainstream, go where the evidence is and go where the experts go, right? Which is where you're going as well.
Exactly.
Dr. Weiss, I just wanted to, because the first question, I don't think we answered this. How can you tell if you're experiencing perimenopause or menopause if you're on an IUD, a Mirena IUD? That was the first question. I just want to make sure that we flag that. And then anyone else who is asking questions, we'll make every effort in the mail out that follows, which it will include the link to this presentation on YouTube as well as on Medcan LiveWell. We'll try to answer all of these questions. But Dr. Janice Weiss, do you mind just answering that one question?
Absolutely. So that's a very good question. And it's a similar answer to how does a woman who's had a hysterectomy know that they're in menopause? Because you're not seeing a period flow as a result of your Mirena IUD. So basically you go by symptoms, and not everybody gets symptoms, but there's no harm in keeping your IUD in longer. As I said, menopause can be up to age 58, 56, 58. Those are normal years. And if you don't have symptoms of menopause, then you can just keep your IUD in. When it's time to replace it, at that point, you can always consider a blood test. That way you would know whether or not you need to have another one replaced or not. So basically it's based on symptoms. Hot flashes, night sweats.
And is there a family history component? I've always been told, the gynecologists say, ask your mother if you can, how old she was when you went through midlife. I don't know if that's an old wives' tale or not, whether it tends to run in families, because people who have later or more severe menopause, whether it's genetic or not, it's an interesting conversation. I don't have the answer to.
Yeah, symptoms possibly, because there are ethnic differences in symptoms and cultural differences in symptoms. So it's possible.
Well, this was fantastic. Thank you so much to both of you, as well as to webinar attendees. Just a few administrative things. Our next webinar, we're skipping because the next webinar falls typically in 2 weeks. It falls in that holiday period around Canada Day. So the next webinar is actually July 13th. It's how to create an exercise habit. And in very detailed way, our trainers, two of our top trainers, will be walking through exactly how to go about making it a habit to exercise. And so that's going to be a good one. Another upcoming resource, so the latest podcast on the Eat, Move, Think podcast, which is eatmovethinkpodcast.com, or on Apple or Spotify or Google, is Post-Pandemic Psychology with Dr. Stephen Taylor, and that features Dr. Jack Muscat interviewing Dr. Stephen Taylor about how we're getting out and what to expect over the next months as we transition to whatever's next. Thank you to webinar attendees. Thank you to Dr. Janice Weiss. Thank you to Dr. Beth Abramson. This was amazing. And let's do something similar soon. So we need to, the two of you are so great together. So thanks very much.
Enjoyed it.
Flattery will get you everywhere. Just thank you for listening, and it's an important issue.
Exactly. Take care, everybody.